Welcome to the Dr. Izzy's Medical Podcast channel.
Iron overload. Iron overload or hemochromatosis indicates accumulation of iron in the body from any cause. The most important causes are hereditary hemochromatosis, a genetic disorder, and transfusional iron overload, which can result from repeated blood transfusions. Signs and symptoms. Organs most commonly affected by hemochromatosis include the liver, heart, and endocrine glands. Hemochromatosis may present with the following clinical syndromes: liver, chronic liver disease and cirrhosis of the liver; heart failure, cardiac arrhythmia; hormones, diabetes and hypogonadism, which leads to low sex drive and/or loss of fertility in men and loss of menstrual cycle in women; metabolism, diabetes in people with iron overload occurs as a result of selective iron deposition in islet beta cells in the pancreas, leading to functional failure and cell death; skeletal, arthritis, from calcium pyrophosphate deposition in joints leading to joint pains. The most commonly affected joints are those of the hands, particularly the knuckles of the second and third fingers. Skin, melanoderma, which is darkening or bronzing of the skin. The skin's deep tan color, in concert with insulin insufficiency due to pancreatic damage, is the source of a nickname for this condition as bronze diabetes. Causes of hemochromatosis. The term hemochromatosis was initially used to refer to what is now more specifically called hemochromatosis type 1. Currently, hemochromatosis is mostly defined as iron overload with a hereditary or primary cause or originating from a metabolic disorder. However, the term is currently also used more broadly to refer to any form of iron overload, thus requiring specification of the cause, for example, hereditary hemochromatosis. Hereditary hemochromatosis is an autosomal recessive disorder with estimated prevalence in the population of 1 in 200 among patients with European ancestry, with lower incidence in other ethnic groups. The gene responsible for hereditary hemochromatosis is located on chromosome 6. The majority of hereditary hemochromatosis patients have mutations in this HFE gene. Hereditary hemochromatosis is characterized by an accelerated rate of intestinal iron absorption and progressive iron deposition in various tissues. This typically begins to be expressed in the 3rd to 5th decades of life, but may occur in children. The most common presentation is hepatic, liver, cirrhosis in combination with hypopituitarism, cardiomyopathy, diabetes, arthritis, or hyperpigmentation. Because of the severe sequelae of this disorder if left untreated, and recognizing that treatment is relatively simple, early diagnosis before symptoms or signs appear is important. In general, the term hemosiderosis is used to indicate the pathological effect of iron accumulation in any given organ, which mainly occurs in the form of the iron storage complex hemosiderin. Sometimes, the simpler term siderosis is used instead. Other definitions distinguishing hemochromatosis or hemosiderosis that are occasionally used include: hemosiderosis is hemochromatosis caused by excessive blood transfusions, that is, hemosiderosis is a form of secondary hemochromatosis. Hemosiderosis is hemosiderin deposition within cells, while hemochromatosis is hemosiderin within cells and interstitium. Hemosiderosis is iron overload that does not cause tissue damage, while hemochromatosis does. Hemosiderosis is arbitrarily differentiated from hemochromatosis by the reversible nature of the iron accumulation in the reticuloendothelial system. The causes of hemochromatosis broken down into 2 subcategories: primary cases, hereditary or genetically determined, and less frequent secondary cases, acquired during life. Secondary hemochromatosis. Severe chronic hemolysis of any cause, including intravascular hemolysis and ineffective erythropoiesis. Multiple frequent blood transfusions, which are usually needed either by individuals with hereditary anemias, such as beta thalassemia major, sickle cell anemia, and Diamond-Blackfan anemia, or by older patients with severe acquired anemia such as in myelodysplastic syndromes. Excess parenteral iron supplements, such as what can acutely happen in iron poisoning. Excess dietary iron. Some disorders do not normally cause hemochromatosis on their own, but may do so in the presence of other predisposing factors. These include cirrhosis, steatohepatitis of any cause, porphyria cutanea tarda, prolonged hemodialysis, and post-portacaval shunting. Diagnosis. There are several methods available for diagnosing and monitoring iron loading. Blood test. Blood tests are usually the first test if there's a clinical suspicion of iron overload. Serum ferritin testing is a low-cost, readily available, and minimally invasive method for assessing body iron stores. However, the major problem with using it as an indicator of iron overload is that it can be elevated in a variety of other medical conditions including infection, inflammation, fever, liver disease, kidney disease, and cancer. Also, total iron binding capacity may be low, but can also be normal. In males and postmenopausal females, normal range of serum ferritin is between 12 and 300 nanograms per milliliter. In premenopausal females, normal range of serum ferritin is between 12 and 150 or 200 nanograms per milliliter. If the person is showing the symptoms, they may need to be tested more than once throughout their lives as a precaution, most commonly in women after menopause. Transferrin saturation is a more specific test. Genetics. DNA screening, the current standard of practice in diagnosis of hemochromatosis, places emphasis on genetic testing. Positive HFE analysis confirms the clinical diagnosis of hemochromatosis in asymptomatic individuals with blood tests showing increased iron stores, or for predictive testing of individuals with a family history of hemochromatosis. The alleles evaluated by HFE gene analysis are evident in 80% of patients with hemochromatosis. A negative report for HFE gene does not rule out hemochromatosis. First-degree relatives of those with primary hemochromatosis should be screened to determine if they are a carrier or if they could develop the disease. This can allow preventive measures to be taken. Screening the general population is not recommended. Biopsy. Liver biopsy is the removal of small sample in order to be studied and can determine the cause of inflammation or cirrhosis. In someone with negative HFE gene testing, elevated iron status for no other obvious reason, and family history of liver disease, additional evaluation of liver iron concentration is indicated. In this case, diagnosis of hemochromatosis is based on biochemical analysis and histologic examination of a liver biopsy. Assessment of the hepatic iron index is considered the gold standard for diagnosis of hemochromatosis. Magnetic resonance imaging is used as a non-invasive way to accurately estimate iron deposition levels in the liver as well as heart, joints, and pituitary gland. Treatment for hemochromatosis. Phlebotomy. Phlebotomy, venesection, routine treatment consists of regularly scheduled phlebotomies. When first diagnosed, the phlebotomies may be performed every week or fortnight, until iron levels can be brought to within normal range. Once the serum ferritin and transferrin saturation are within the normal range, treatments may be scheduled every 2 to 3 months depending upon the rate of reabsorption of iron. A phlebotomy session typically draws between 450 and 500 milliliter of blood. The blood drawn is sometimes donated. Diet. A diet low in iron is generally recommended, but has little effect compared to venesection. The human diet contains iron in two forms, heme iron and non-heme iron. Heme iron is the most easily absorbed form of iron. People with iron overload may be advised to avoid food that are high in heme iron. Highest in heme iron is red meat such as beef, venison, lamb, buffalo, and fish such as bluefin tuna. A strict low iron diet is usually not necessary. Non-heme iron is not as easily absorbed in the human system and is found in plant-based foods such as grains, beans, vegetables, fruits, nuts, and seeds. Medication. Medication. For those unable to tolerate routine blood draws, there are chelating agents available for use. The drug deferoxamine binds with iron in the bloodstream and enhances its elimination in urine and feces. Typical treatment for chronic iron overload requires subcutaneous injection over a period of 8 to 12 hours daily. Two newer iron chelating drugs that are licensed for use in patients receiving regular blood transfusions to treat thalassemia are deferoserox and deferiprone. Chelating polymers. A minimally invasive approach to hereditary hemochromatosis treatment is the maintenance therapy with polymeric chelators. These polymers or particles have a negligible or null systemic biological availability and they are designed to form stable complexes with iron 2 and ferric ion in the gastrointestinal tract and thus limiting their uptake and long-term accumulation. Although this method has only a limited efficacy, unlike small molecular chelators, the approach has virtually no side effects in subchronic studies. Interestingly, the simultaneous chelation of iron 2 and ferric ion increases the treatment efficacy. Prognosis. In general, provided there has been no liver damage, patients should expect a normal life expectancy if adequately treated by venesection. If the serum ferritin is greater than 1,000 micrograms per liter at diagnosis, there is a risk of liver damage and cirrhosis which may eventually shorten their life. The presence of cirrhosis increases the risk of hepatocellular carcinoma.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.